So welcome to the first day of rounds of the new academic year. Today we have the pleasure of hosting Dr. Seward from Mount Sinai West in St. Luke's for a talk on Hermansky Pudlak syndrome. Dr. Seward received his medical degree from the University of Texas Southwestern School of Medicine, and he trained in internal medicine and pediatrics at St. Vincent's Hospital. He joined the Sinai faculty initially in 1994 as an associate professor, and later was program director of the combined internal medicine and pediatrics residency program. In 2004, he joined the faculty of Columbia University Medical Center, where he ultimately served as associate vice president of Columbia Health. Dr. Seward returned to Mount Sinai in 2016 as chair of the Department of Medicine at Mount Sinai West and St. Luke's. He's an associate professor of medicine at the Icahn School of Medicine. Dr. Seward is internationally known for his work with the Hermansky Pudlak syndrome patient population. His clinical interests include the care of adult patients who are survivors of congenital and pediatric disorders. Please join me in welcoming Dr. Seward.
Thank you. Hi, good morning. I really appreciate everyone being here and appreciate the opportunity to talk about my favorite congenital syndrome, hoping that it will be an important place for you to learn about HPS, certainly, but also think about rare diseases and rare disorders in terms of our general understanding of health and illness in human populations. I don't have any disclaimers for this talk, but I do want you to know I'm going to show some pictures of patients. In every case that I do, I have their permission to do so. I don't name any of them, but nonetheless, just want you to be aware of that fact. You all are familiar with the definition of syndrome, and I think congenital syndromes are an important place to think about Occam's razor and how we can make sense of symptoms or signs that can seem confusing and disparate and only come together in an organizing way once we understand particularly the cellular mechanism, but also the mutational mechanism of a particular disorder. This is what we'll review, all the things that you would expect. I will spend a couple moments, and this is in particular for our new interns, and I want to welcome you to Mount Sinai. I understand this is the first grand rounds. There are going to be a host of great grand rounds, so we want you to come to all of them. And I hope that those of you who are thinking about what you'd like to do with your careers will think about doing primary care, and I'll share with you how a person like me, who's a true generalist, can have an impact in caring for patients with a very rare and complex disorder. Hermansky Pudlak syndrome was described in the 1950s by Dr. Hermansky and Dr. Pudlak. From fairly good information, my understanding is that, and this is pre-revolutionary Czechoslovakia, my understanding is that Dr. Hermansky was a true clinician scientist, had two separate women patients present to him with clear albinism and issues with bleeding. He did some initial studies, bone marrows and other things to try to understand what was going on with them, and then published his result, or went on the way to publishing his results. Pudlak, and again, I have this on good information, was really nothing more than a Communist Party hack, and was able to get his name onto this paper and into the annals of medicine based on that connection. HPS is important for a number of reasons. It's important because it's rare, and we're going to talk a little bit about what rare diseases are. It's important because it has things to teach us about some of the basic genetic principles like locus heterogeneity. And it's important because to the extent we understand the cellular mechanism, we do for a number of the HPS mutations, it can tell us broader things about human illness. The phenotypic presentation of HPS includes oculocutaneous albinism, and when these patients present to you, they may complain of things like photophobia. You may notice horizontal nystagmus. It can be quite prominent and often quite distressing to patients. And they will typically be legally blind. They have a bleeding diathesis that we'll discuss in some detail related to a platelet abnormality. And then the most devastating complication of this disorder is interstitial lung disease. And there's a percentage of patients with certain mutations who also get inflammatory bowel disease. So these are the 9 published mutations associated with HPS, and they all give you phenotypically the 2 central features that are required. So they all give you oculocutaneous albinism, and they all give you the platelet defect. Types 1, 2, and 4 are associated with the interstitial lung disease, and then 1, 4, and 6 with the inflammatory bowel disease. In type 1, we know, although this is unpublished data, we know that 100% of patients with the HPS1 mutation, which is also sadly the most common by far, those patients will go on to develop ILD. It's an autosomal recessive disorder. The HPS1 gene, which again is the most common, is associated with a 16 base pair duplication. And again, as I noted earlier, there are functional issues at the level of organelles, intracellular organelles, that give you the phenotypic presentation of this disorder. So just to take a step back and talk briefly about rare diseases. Rare diseases are rare by definition. In the United States, we say if the frequency is less than 1 in 200,000 people, that's a rare disease. If we were in Japan, the definition would be less than 1 in 50,000. I don't think that's me. No, good. So definitions vary by country. This is from the online Mendelian Library of Rare Diseases, and I pulled this data just a few months ago, so it's probably been updated. And what we have is 387 human diseases where we both know the molecular mechanism and also the genetic mutation. Another 2,300, we've worked out the molecular mechanism. We're still trying to understand the genetic mutation. There's 1,600 where there's a clear Mendelian pattern of inheritance, but we neither know the mutation nor the molecular mechanism. And then there's another 2,000 and change where there's a strong suspicion that it's a genetic-based disease or mutational-based disease. So that ends up giving us somewhere around 6,500 human diseases where genetics are central. And that represents, it's estimated in this country, about 30 million patients. So though any given syndrome like HPS is rare, when you talk about rare diseases writ large, they're quite common. And you're very, very likely to see patients with rare diseases, perhaps not every day, but certainly on a weekly basis, in my opinion. Some of them are better known to us. Alpha-1 antitrypsin, achalasia are both rare diseases. And for reasons that I don't think are completely explained by frequency or by the importance of what we learn from them, they're kind of part of how we think about patients. A patient presents with emphysema in middle age, very quickly we're thinking about alpha-1. Things like HPS, for whatever reason, are less commonly known in the medical community. And again, I don't think all the reasons for that are necessarily related to frequency or other matters. This is a gel electrophoresis. This represents the 16 base pair duplication. I've done this work here. This is not my gel, but it's pretty straightforward to do. So bands 5 and 6 represent 2 patients with the HPS1 mutation. 3 and 4 are normals, and 2 is a control. The most common mutation, as I mentioned, is HPS1. And if you go to the northwestern region of Puerto Rico, which historically was a rural and agrarian part of the island. More recently, in the last 30 years, it's become a very popular place for surfers, and there's a lot of resorts there now. If you fly into Aguadilla and you happen to see a person with albinism, dollars to donuts, that patient has HPS. And the reason is because the carrier frequency in that portion of the island is about 1 in 18. And the affected incidence is about 1 in 1,200. So those numbers, the 1 in 18 in particular, approach what we think about with things like cystic fibrosis, for example. HPS3 has been described in the center of the island, and it's an example of the founder effect, which I imagine many in the audience are familiar with. And it's the idea if you have a mutation that gets overexpressed in a population, one of the reasons why it might have been overexpressed is because the early descendants of that population, isolated from a larger population, sometimes over the course of generations, will have overrepresentation of that particular mutation. And again, that's an example of the founder effect. The other thing I mentioned earlier, which I'll talk briefly about in a little more detail now, is another central concept with HPS is locus heterogeneity. And it's pretty much what it sounds like. You can have a phenotypic presentation and numerous mutations that give you that, and that's locus heterogeneity for the Newhouse staff. Although we think about Puerto Rico with HPS, it's been described all over the world. The HPS Foundation, which is referred to as the HPS Network, does a wonderful job of tracking patients, and this is a map from the network showing where this syndrome has been described throughout the globe. Diagnosis is pretty straightforward. If you think about HPS, in the exam room, we can look for oculocutaneous albinism, and I'll share with you how to do that in a moment. It's good to do a pedigree analysis for any autosomal recessive disorder, including HPS, because it can skip generations. So we're asking about, do you have any family members with a history of albinism? And patients will typically know. Albinism is one of those features that people know about and think about because it affects their lives so profoundly. So if you ask, is there anyone else in your family with albinism, they'll be able to tell you if they're aware of that. Early deaths secondary to lung disease, they may not know why, but they'll know if that happened. And bleeding are the things we ask for in our pedigrees. We can do platelet studies. Currently, we're using the Mayo. We have used Sinai in the past, and I'll share how we do that in a moment. And then more and more, we're doing mutational analysis, which is available through commercial labs for certain of the mutations. Just to make the point, albinism, of course, is described in many animals, including humans. So here's what we do in the exam room. With a direct ophthalmoscope, you can look for two findings that will show you ocular albinism. The one in the middle slide is called iris transillumination. So you're shining light through the pupil. And for anyone with light sensitivity, you always check to make sure that it is not bothering them. And with iris transillumination, the light goes through the pupil and comes back out through the iris. And so all the areas in that iris that look yellow or light orange or red are areas of hypopigmentation. The only normally pigmented areas is the area on the left, or the temporal region, the nasal region, which is darker in color. Likewise, the retina, all the areas where you see light orange or yellow, that's hypopigmented retina. And so you walk into the room, you're looking for evidence of cutaneous and skin albinism, or cutaneous and hair albinism, as well as these eye findings. Now, the cutaneous and hair findings can vary. And so these two patients, this is from Bill Gall's original series, these two patients both have HPS1, so they have the same mutation. In women with albinism, sometimes men, one reason why their hair won't look hypopigmented is because they dye it. But this patient didn't. And the point that's being made here is that the degree of hypopigmentation can vary one patient to another, even with the same mutation. Albinism, when we're talking about ocular albinism, there's tyrosinase positive and negative, and I think many will remember that from medical school. This is an example of tyrosinase positive albinism. It has to do with the fundamental cellular mechanism of this disorder. So on the basic level, HPS patients can make melanin. They can't transport it where it needs to go. There are other congenital causes of albinism, Chidiac-Higashi, Griscelli syndrome, or other causes. For the house staff, were you to see this neutrophil on an exam, think Chidiac-Higashi. Those are the classic CHS granules you see in neutrophils. You can see them in melanosomes as well, actually, but in neutrophils that are associated with that disorder. And these are HPS platelets on the right and then normals on the left. And it's pretty obvious what the difference is between the two. So on the right are 3 separate platelets with absence of delta or dense granules. And then on the left are 3 non-HPS platelets where you see the typical number somewhere between 3 and 10 delta granules per platelet. Delta granules as well as alpha granules are important for platelet stimulation, and they release their contents, ADP, calcium, epinephrine, and lead to further aggregation of platelets. Now, it's not to say that patients with HPS can't clot at all. They can. What they have, their platelets clot, or they aggregate in 2 phases, the primary phase and a secondary phase or wave. And patients with HPS have delayed secondary wave of aggregation due to the fact that they're not releasing the contents of delta granules and they don't get that extra stimulation. And you can track this over time using light. It's very straightforward to do, and you just track over time the formation of clot. And as I say, patients with HPS predictably will not clot as fast. Just to remind the house staff, we think about quantitative and qualitative disorders. In my opinion, We tend to think and focus on quantitative disorders, particularly when we're in the ER and we have patients present with bleeding, other than von Willebrand's. Von Willebrand's typically comes pretty quickly to our minds, but other qualitative disorders, not so much. And again, in my, really my understanding of human disease, I'm not sure there's a great reason for that. It's just kind of the way things play out. And typically you'll hear doctors talk about in ERs, and my patients tell me this all the time. They check the platelet count was normal, and we're done. It can't be a platelet issue. Well, of course, it can be a platelet issue if a patient has a qualitative platelet disorder. And this slide is again from Bill Gall's original study or series in the New England Journal, just to make the point, HPS patients, other patients with qualitative platelet disorders will make a normal number of platelets. And so you have to dig deeper for the house staff in order to understand what's going on for these patients. I wanted to go back to rare diseases and just remind the audience that Glanzmann's, which is an issue with one of the two major proteins, the 2B3A protein, was originally described because the folks that were interested in understanding what was going on for these patients took the time to work out what was happening at the cellular level. And one of those people, of course, was Barry Kohler, a former chairman here. And Barry was the person who first got me interested in taking care of HPS patients. Subsequent to that, we have ReoPro, and it's an example of where rare disorders, particularly when we can understand the mutations and ultimately the cellular mechanism of disease and the phenotype, can really impact much larger populations of people. And ReoPro, of course, has saved many patients post-cath as they're in the CCU, and we're worried about them reclotting. Patients with HPS and other qualitative disorders can present very early in life with bleeding issues. They don't always. For the parents in the room, one of the ways they can present is when the toddlers are first learning how to walk. And they're sort of crashing around and they crash into things. They end up with bruises that if the parents aren't aware their child has HPS or the provider's not aware their child has HPS, they won't make those connections and they'll start thinking about child abuse. And I've had anecdotally patients tell me about that. Menarche is another very important time where bleeding disorders can negatively impact women's lives, sometimes in really profound ways. I've had patients stop working, go part-time in school because of the menarche and bleeding of their lives, menstruation and bleeding in their lives. Childbirth, we always manage these patients as high risk because of the bleeding disorder. And then the others are pretty obvious, certainly trauma, dental procedures, we're managing them different than we would otherwise. Organ transplantation I'll talk a little bit about later. It used to be a place where we needed to talk a lot with our surgical colleagues about the risk, but I think we're doing a pretty good job of managing that now. And this is just a typical bruise. I don't know this patient, but my guess would be he wouldn't necessarily even remember how he injured his leg. You can see fairly significant intramuscular bruising and have to manage patients for that, but that's relatively rare. But bruising in general is quite common. The HPS IBD is an important phenomenon phenotypically for a subset of patients, and again, it's patients with 1, 4, and 6. They present, as you would expect a patient with IBD to present, with crampy abdominal pain, fever, many loose bowel movements per day, and what have you. Histopathologically, it looks a lot like Crohn's. We don't call it Crohn's because we don't think the mechanism of disease is Crohn's, but we actually don't know. And we're really delighted to have, is that for a code? Good luck, guys. We're very lucky to have Louis Cohen working with us now, who's in the GI division here at Mount Sinai. Louis, as perhaps some of you know, is interested in the microbiome, but has already been working with our patients and going back one step further and trying to help us understand the natural history of these patients better. And then following that, we're anxious to see if Louis might be able to find ways to help us understand what's going on mechanistically. It's been thought that a putative insult for the gut is ceroid lipofuscin, which is what it sounds like. It's a fatty proteinaceous deposit that probably has to do with cellular debris and inability to transport that debris out of the cell over time. But we don't actually know that. It's just a putative insult for these patients. One point I wanted to make is just that with severity scales, the bleeding is a place where you just have to be a little bit careful. So if you look at Crohn's activity indices, they usually will include something about bleeding. The most common one that I'm aware of, hemoglobin can be an indicator, and you get points based on how low the hemoglobin is under normal. And it's just to make the point, in a patient who additionally has a bleeding disorder, that needs to be thought of in that context. And so the severity might not be quite as much as you otherwise would assume. Interstitial lung disease, as I mentioned, is the most devastating phenotypic complication of this disorder, and the HPS-1 population, based on unpublished data, it's 100% of these patients will develop interstitial lung disease, which looks in most respects like pulmonary fibrosis. It's also something we can see in 2 and 4, but again, those mutations are much less common. What distinguishes it, first and probably most importantly, is when patients present is different than you would expect, for example, with idiopathic pulmonary fibrosis. And other than knowing it's associated with HPS, it is truly idiopathic. So our patients can present very early in life. They don't always, but they can. We've had patients in their late teens and early 20s with symptoms of pulmonary fibrosis. And likewise, mortality is adjusted lower for these patients because they present early. For the house staff in the room, just to remind you, when we think about lung diseases and we're doing pulmonary function tests, we think about obstructive and restrictive, and this is a restrictive disorder. Maria Padilla, who's worked with our population for years and has been a wonderful support to us and advocate for these patients, she and I have talked about how sometimes you can see an asymmetric decrease in the DLCO with all the other parameters, in particular the volumes, being normal initially. I don't think to this day we really totally understand why that's the case, but it's something that we'll sometimes see in these patients. Again, it's pretty straightforward. When you're thinking about interstitial lung disease, and particularly pulmonary fibrosis in a patient you know have HPS, the signs they'll present with are pretty straightforward, as well as the symptoms. The symptoms are usually a dry cough. My anecdotal experience is that it's not unusual. They've had an antecedent upper respiratory infection, maybe a fairly significant one, and they'll go back to that moment and they'll say, everything got better, but the cough persisted. It's dry in the sense that it's truly non-productive. It can bother them throughout the day and night, and sometimes can really be a major impact on their lives. They will have dyspnea on exertion with progression of illness, as you would expect. They will have exercise-related hypoxia, and we document that with a 6-minute walk test. And then when you listen to them, it's a basilar disease that progresses in a cephalad direction. On testing, as I mentioned, it's a restrictive disorder. We will do baseline high-res CT or other times when it's indicated for patients. So the way we manage these patients, and Bill Gall and I published a review of how to manage these patients a couple of years ago. We do PFTs starting at late teens annually and then semi-annually as patients age into their 20s. We do a baseline high-res CT, and then we'll repeat it, as I mentioned, as it's clinically indicated, but not on an annual basis. Mark Brantley, to my knowledge, published the largest study. This is a rare disease, so it's hard to do big studies in rare syndromes. And Mark, I thought there were a number of important findings from his study. Mark's now at the University of Florida, one of which was when you looked at the whole population of patients, and he had basically half that were asymptomatic and half that were symptomatic. He showed that with high-res CT, 80% of the entire group would have some evidence of changes that you would associate with ILD, and specifically fibrosis. Now, having said that, one of the features of HPS ILD that distinguishes it from IPF is you can see ground glass, and I think most in the audience will know that ground glass is not usually a typical feature you look for with pulmonary fibrosis of other causes, and we think of it more with things like eosinophilic pneumonitis, mycoplasma pneumonia, and what have you, hemorrhage in the lungs. But ground glass is it's certainly not a pathognomonic feature for HPS ILD, but is something we see fairly frequently. And this series is all from the same patient who had significant disease and succumbed to that disease. We are trying to understand what's going on in the lungs, and I think one of the major contributors for us has been Susan Gutentag, who's now at Vanderbilt. The upper slide just shows you some foamy macrophages in the lungs, and that's another feature that's different than what you would expect. You can see a macrophage predominance in BAL fluid in HPS patients, where it's thought that that foaminess is from, again, the ceroid lipofuscin, but I don't think that's really been worked out. On the left, you see typical scarring and cyst formation in patients with advanced pulmonary fibrosis and HPS. On the right are those populations of macrophages I mentioned. And this is from Susan's work, although this paper was published by Bernadette Gochico at the NIH. And Susan has looked at the lamellar bodies, which are the site of surfactant storage in type 2 pneumocytes. And you can see, even if you know nothing about lamellar bodies, you can see these look pretty big for intracellular organelles, for subcellular components. And Susan's tried to help us understand what's going on there, and that's another feature of this disorder. And those are represented by the white arrows. We have looked at the natural history of interstitial lung disease in HPS patients, and we know when their FVC drops below 50%, they have roughly about a 2-year survival rate, and when it drops below 30%, it's really not consistent with life. Thankfully, transplantation has come into the HPS community, and in this picture you see 2 patients. The patient on the left, and I have her permission to tell you this, was transplanted at UT Southwestern about 5 years ago. The patient on the right was my patient, a lovely person who succumbed to her disease on the transplant list in the past year or so. That Chihuahua was the bane of my existence when I ever visited her at home. Would not stop barking. So we're really happy that we have gotten patients through transplant. It's typically double lung. I've lost track, but I think the number's around 18 patients now who have received lungs with HPS. This is a description of one of the early procedures which was done at Columbia during my time there. And Salim Arkasoy is the director of the transplantation program on the medical side. He's not a surgeon. As I mentioned early in my talk, when we first were trying to talk to transplant surgeons about bringing our patients into the operating room, they were very concerned about the bleeding diathesis. But I think we've done a very good job of reassuring them that we can manage that, and we have the experience now of being able to manage that. With platelets, of course, normal platelets will clot in a patient, and so we always have platelets on call. Certainly for this procedure, but any major surgical procedure will have platelets on call. And then also DDAVP has played a really important role pre-op in getting these patients to the operating room, and we'll give it IV. This is old news now. I mean, the world really changed for patients with pulmonary fibrosis with 2 products being brought to the IPF population that were just such exciting news. And I wanted to mention them. This particular product, nintedanib, is not appropriate for HPS patients because of the bleeding disorder. But it, as well as pirfenidone, I thought it was an important moment for the house staff to recognize. When we're talking about mortal illnesses, and if you go back 20 years or so, when we were talking about drugs coming to the market and FDA approval, it often was linked to whether we could cure that disease or not. And at least in my experience, starting with cystic fibrosis and nebulized TOBI, a different paradigm came to the fore. And that was, well, let's see if we can just make these patients feel better. So in the old TOBI study, we were looking at FEV1 and the decrement of FEV1 over 6 months of the patients who were on that drug. In the pirfenidone trial, as well as the Impulsus trials, we were looking at FVC. We can predict what the decrement of FVC will be over time with patients with pulmonary fibrosis. And what these trials showed was that if you give them the drug, it slows down. And that, to me, was a very important moment in healthcare and certainly in the history of how drugs get FDA approval, and very important, of course, for patients. The other point I wanted to make was cystic fibrosis is a very important example of patient advocacy and family advocacy. And there were patients and families, even at that time, pushing for drugs like TOBI to come to market to make people feel better, not save their lives, but extend their lives, and importantly, extend the quality of their lives. There have been 2 pirfenidone trials in the HPS population, again, both small because it's a rare disease. In this first trial, what we showed, or I think the authors of the trial and all of us who have reviewed this trial would not want to overstate this. We think that it showed some benefit for patients with either minimal or moderate disease. It clearly did not benefit patients with severe disease. Very anecdotally, and Maria will know this patient, I had a patient on pirfenidone for over a decade, clearly had interstitial lung disease. She ultimately succumbed, but not to her interstitial lung disease. She succumbed due to complications from IBD. So it's, it's one case. This is a small study, but we really do believe pirfenidone has a role for these patients. The second study was stopped early, essentially because we couldn't really show that it was either benefiting or hurting patients in any way that would suggest the study should be continued. So it was discontinued, and so we don't have the results of running those patients all the way through. So we're going to talk briefly about the cellular mechanism of HPS as we understand it, and I think we understand it best for the HPS2 population, and has to do with how transport happens within cells. And so these are the 9 mutations, and what you see down below are the AP3 complexes as well as the block complexes, and I imagine many in the room are familiar with these for other reasons. These are subcellular components. They all have to do with clathrin and non-clathrin related vesicular formation. And what we know in the HPS2 population, both from murine models and also human models, is that there's a mutational defect in AP3. So those vesicles are not, those pits and ultimately the vesicles are not formed normally. AP3 interacts with block 1, and then block 2 and block 3 are also in the same sort of realm, late in the Golgi complex and what's happening there in that machinery over time. So this is where we are with our understanding of the cellular mechanism of this disorder. And this just makes the point, we've got lots of murine models. Were you to be a person that might be interested in studying HPS, we can get you mice. Oh, I'm sorry, let me see what I'm doing here. Here we go. And I just wanted to reiterate what we understand about the HPS2 mutation. To my knowledge, there's only 3 patients that have been described with this mutation internationally. There was a twin set from Canada, and then this cute little boy, all of whom have this mutation. HPS2 has some other interesting features, including issues with early infection and related immunologic issues. Okay, so I'm going to finish up by talking a little bit about what I do, and then also talk about the foundation. And we're doing okay on time. Yeah. So again, I'm a generalist. I'm a general internist, first and foremost. I'm also a general pediatrician. And the role I've had in these patients has to do with how they first came to me, which was by way of the network and the foundation, and the founder of that foundation recognizing that she needed a locus for these patients to get care in New York. There's a lot of these patients in New York. There's a lot of movement back and forth from Puerto Rico. My population is about 75% HPS1. They're not all from Puerto Rico. The majority are. I also have HPS3 patients, and I have 1 HPS6 patient. And my role was really to do what's come to be called transitional medicine, which is caring for adults who are survivors of pediatric and congenital disorders. Over the course of the 20 years or so that I've been doing this, I think I've seen about 100 patients. And that, again, is just to reiterate it, you will see these patients. I think you'll be hard-pressed for the interns in the room to get through 3 years at Sinai and not see an HPS patient. You may not know, they may not have come to diagnosis yet, but they are out there. Currently, I'm following about 30. And one of the challenges for any rare disorder, or any chronic syndrome, I would even say, is trying to remember the whole patient. And I find the same challenge. I tend to be very focused on what's going on for them as an HPS patient, and I can sometimes forget to think about the other things I need to do. So vaccines, for example. I can stop thinking about heart health. And I have patients, not a few, that have hyperlipidemia, for example, which we don't think is secondary to the disorder as far as we know, but it is something that Americans tend to get, Puerto Ricans tend to get. Any patient with albinism is at increased risk for all the three major types of cutaneous malignancies, so squamous, basal cell carcinoma, and melanoma. And what we know, for example, from looking at albino populations in sub-Saharan Africa, if you take their counterparts from the same communities, with the basic same mix of who are normally pigmented, you can see in the albino population the rates of malignancies are dramatically greater than they are in patients who are not hypopigmented. And so I need to do good skin checks or making sure I'm referring these patients to the dermatologist to do so. This is really for all of you. These patients, again, generally speaking, are legally blind. Many of them drive. So I just thought you should know that. They drive because it's tough to not drive, and particularly from other parts of the country, not so much New York City, but I have patients from all over the country, and it's pretty challenging to get around. So just be ye aware. Genetic counseling can play a role. At a place like Sinai, we have such great genetic counseling available to us through the genetics department, so not necessarily as much an issue. But depending where the house staff, for example, will practice, you may not have the same resources available to you. And so it's important to think very seriously about counseling pre and post tests, kind of in the framework we use for HIV testing. And these are some of the questions I try to remember to ask myself as I'm going into that testing. And I have many patients, that's really why they come to see me, is for a rule-out kind of diagnosis. I will always write down a Punnett square for them, and the reason I do is trying to make this conceptual thing concrete for them. And so it's an autosomal recessive disorder, so only 25% of patients in a given pregnancy, or only 25%, there's only a 25% risk. You can see why I do this for my patients. There's only a 25% risk for any given pregnancy of having an affected baby. But it's hard for patients to understand, and so this is a set of 3 children. The boys are not twins. The parents had the oldest child, the daughter, didn't get that, thought it was 25% lifetime risk for their marriage, and went on to have subsequent babies, and just never were able to take in, no, with each pregnancy you have to worry about it. Post-counseling is important too, and these are some of the questions I try to sit down and go through. What I try to reassure patients is, because they often will have, they're anxious. They're anxious because it's tough being albino. They're anxious because it's tough having a bleeding disorder. And so they come to me in an anxious state. And what I try to reassure them is, yes, we can do this test, but let's take some time to think about why we're doing it. And I also try to reassure them, I'm not going anywhere. Even though I left Columbia, I'm now in Mount Sinai. You can find me. And we can do the test next week, or we can wait. And let's see what makes sense for you and your family, and try to pose it to them this way. Because also, often, they'll have a great sense of urgency about getting it done now, but not always for the right or the best reasons. So I just wanted to shift gears again and talk briefly about the network and the foundation. And again, it's to make this broad point that to me, another major moment in healthcare was patient advocacy and family advocacy. And we live in a world where that is part of what we do. It has to do with how we care for patients. It has to do with what drugs get approved. It has to do with how the NIH is thinking about approving trials. And Donna Appel, who's the woman on the right, and that's her daughter Ashley, she sits on, and has for a number of years, the patient advocacy group, has the ear of the head of the NIH when it comes to issues, not just related to HPS, but issues writ large for rare syndromes and diseases. It has to do with how our legislators are thinking about approving or not approving legislation as it relates to healthcare, again, writ large. And so the HPS network does a lot. It's a small foundation. I don't think anyone would mind on the foundation side me telling you it typically has about a $200,000 budget. So if you're looking for ways to spend your hard-earned dollars, we would welcome. But they do things locally and they do things internationally. They host conferences, for example, in Puerto Rico, and they've hosted conferences in the UK as well as Japan, other places where this syndrome has been recognized for a long time. As I've already mentioned, they're busy on Capitol Hill. And here's what's next for HPS. We want to better understand the cellular mechanism, and just to reiterate, it's not just for HPS, it's first for HPS, but because it does have broader lessons to teach us. We'd like to see pirfenidone and other drugs approved for this population, and we're working on that. As I mentioned, with Lewis Cohen's help, we're very interested in learning better the natural history of the IBD. And also, there have been various folks that have tried to help us work out inflammatory markers and modulators of IBD, including things we can do in a test tube that can help us understand whether a patient's at risk. We want to understand better subtypes and the prevalence of them, and we really want to get to the end of that list. As I think I mentioned, there's a 10th mutation that's been worked out but not published yet. We think there could be more, but we'd like to get that work done and move on to things that ultimately are more important for patients, and of course a cure is vitally important. Just to acknowledge folks, most of whom I've already mentioned, I'll just mention whom I've not mentioned. Dong Chen is the gentleman at the Mayo Clinic who's doing the platelet studies via EM, and that has been extremely helpful to us. I didn't mention, so I'll say it now. As I'm working up a patient, I'll generally do platelet studies first in concert with Dr. Chen, and then mutational analysis following. And that just makes a lot of sense to me, in part because we can't test for all of the mutations. We're just testing through the commercial labs for the most common and the ones that are CLIA approved. Salim, I mentioned, I sit on the board. I don't have anything to report out because it's a, it's a voluntary position, but I sit on the regular board as well as the scientific advisory board, and Donna as well as my patients and families. So thank you so much. I really appreciate your being here.
Congratulations on resuscitating a Mount Sinai approach using clinical observation and going to basic science. Beautifully done.
Thank you.
I have a question. Have you studied identical twins with this syndrome?
Yes.
What do you find?
It's a great question. The identical twins, of course, have the same mutation, but the phenotypic expression can vary somewhat. Not in its major features. So the identical twins that I'm aware of all have the OCA and the platelet disorder. But when they develop the lung disease can vary, and also they can have other unexpected complications that we think are associated with the disorder, but I don't think we necessarily know. Yes, sir.
I have sort of a general question and a more specific one. Is it known why you get pulmonary fibrosis and inflammatory bowel disease? And that more specifically, are these swollen macrophages surrounded by inflammation? I asked that question because there was a recent article in Science showing that swollen cells attract inflammatory cells.
So, going way back, I mentioned, we have this putative insult for both disorders, the ceroid lipofuscin. But that's really not been worked out, and with the passage of time, just to be candid, it seems more and more like a red herring to me. People have looked closely at the macrophages. I really would not want to represent their work because I, just in the moment don't feel I'm familiar enough with it to respond fully to your question. But that is absolutely a place where people have tried to understand better what's going on for these patients, and more work continues to be done. I don't know if Maria, not to put you on the spot, if you want to respond in any more detail than that.
What's fascinating is that some of the animal models actually develop an emphysema and not a fibrosis. So in order to get fibrosis, you need a second hit, something that is coming on from the environment. Lipofuscin has been found in other diseases that fibrose also. So that may be a nidus, if you want, for attracting fibroblasts or changing the milieu of the environment and causing the fibrosis. Nobody knows.
Thank you. Yes.
Hi. I just looked up and I see that HPS1 is highly expressed in microglia in the brain. I was wondering whether you are aware of any neurological or maybe psychiatric findings, because it has been shown that usually a a non-functional or abnormally functioning microglia can result to some of the neurological or psychiatric diseases.
When you said just looked up, you ran to the library?
No, on myself.
It's a great question. I don't think anyone's looked closely at microglia, but I will tell you HPS2 mutation can be associated, as with Chediak-Higashi, can be associated with some behavioral issues and learning issues. In the HPS1 population, anecdotally, and it's really nothing more than that, but it's drawing from the network their digest of patients, so it's a fairly, kind of impressive anecdote. Learning issues does seem to be an important issue for a number of patients, but it's not been worked out in any detail that I'm aware of.
Any other questions? All right, well, let's thank Dr. Seward for